Good morning and welcome to the term newborn breastfeeding class. My name is Simone. I'm one of the lactation consultants here at Grand River Hospital. To start the class today, we're going to go over some of the materials that you will be taking home with you in your new parent resource package. You should have a large white envelope in your room that your nurse has supplied to you. Inside there are a number of booklets and pieces of paper. The first booklet we're going to focus on is breastfeeding your baby. This booklet is done by Public Health, and it contains all of the information that we will cover today in the class for you to take home as your reference. The second piece of information that I'd like to show you is this page, which is also in your envelope. It's double-sided and it contains all of the information for breastfeeding support in Waterloo Region. The back page has many different options for you to access in our community for continued breastfeeding support. The first column here has the number and information for Public Health, the Public Health Breastfeeding Clinic, which runs Monday to Friday from 8 until 4 p.m. This clinic is by appointment only, so you do need to call to book an appointment. There are many other options on the list for you to review, and there is a column here that tells you which ones are free, covered by OHIP, or at a cost for you individually. The next booklet that we're going to focus on is this one, which is titled Caring for You and Your Baby. This is going to act as your baby's passport for health. You're going to bring this booklet to any family doctor appointments or midwife appointments following discharge. The first page inside your book has a space for all your baby's birth information, birth weight. It also has an area that will have your discharge date and your baby's discharge weight. At the bottom, there's an area for follow-up appointments. If your baby is being discharged at less than 24 hours, you will be required to come back to Grand River Hospital for follow-up blood work, and your appointment will be written down here by your nurse. The next page inside has an area for you to track your baby's weight. So anywhere you take your baby for a checkup after discharge, your baby will be weighed. Ask your healthcare provider to also give you the weight so that you can keep an accurate documentation of those weights. It also talks a little bit here about what is normal weight loss in babies. In the first week of life, it's normal for babies to lose up to 10% of their weight before we intervene or start any additional supplementation. Most babies then regain their weight by 10 to 14 days of age. The last page in this book that we're going to focus on is page 7, which has the guidelines for nursing mothers. This chart has all the information you're going to need at home to help you determine if your baby is getting enough to eat and feeding well. I'm showing you this so that you're aware that you have a copy of this chart in the book, but now I'm going to use my own chart, which is a little bit larger in color, so it's easier for you to see while I'm teaching. The top row here talks about how often you should be breastfeeding your baby. All newborns need to be feeding at least 8 feeds in 24 hours. And you should be able to tell that your baby is sucking strongly, slowly, steadily, and swallowing often. In the first few days of life, the swallows might be very quiet and hard to hear. As your milk supply increases around day 3 or day 4, you will hear more active sucking throughout the baby's feed. In the first 24 to 48 hours, your baby's tummy is only the size of a cherry. It can roughly hold a maximum volume of about 5 to 10 mils per feed. As your baby ages, their tummy size will also grow. By 2 weeks of age, your baby's tummy will have increased to the size of an egg and hold about 60 mils per feed. The next column here talks about urine output. On day 1, your baby needs at least 1 wet diaper. So in the first 24 hours, 1 wet diaper. For each day of life that your baby is, you need to be seeing that many wet diapers. So on day 2, at least 2 wet diapers, day 3, 3 wet diapers, day 4, 4 wet diapers, up until day 5. From day 5 onwards, you should be seeing at least 6 heavy wet diapers every 24 hours to tell that your baby is getting enough input and is breastfeeding well. Moving down to the next column, it discusses the number of stools. So in the first 24 to 48 hours, your baby should have at least 1 to 2 dark green or black stools each 24-hour period. On day 3 and 4, you should have at least 3 stools, and they might be starting to change in color from dark black or brown to a greenish color, or even slightly yellow. By day 5 and onwards, your baby should be having at least 3 soft, seedy yellow stools every 24-hour period. So again, this chart is in your Caring for You and Your Baby book for you to refer back to at home. On the topic of diapers, we're just going to talk a little bit about some of the normals for stools and also for urine output. So it's very important for you to continue to track your baby's feeds and their number of pees and poops for at least 2 weeks after birth or until your baby has reached their birth weight and is gaining weight well. How to tell that your baby has peed in their diaper. You can tell by looking at their diaper. There is a yellow strip on the diaper. If any urine is in the diaper, the yellow strip will turn to a blue color. So even if the diaper is full of stool, you do want to turn it over and have a look to make sure that that you are documenting if there is a blue line, that also means there's pee in the diaper. In terms of stools and what to expect, in the first couple of days of life, first 1 to 2 days, your baby's stool is going to be very dark in color, almost a black looking color. By day 3 or 4, this also corresponds with your milk starting to come in. The stool should start to turn a little bit more of a green color. And by day 4 or 5, the stool should be a nice bright yellow mustardy color. This baby stool can be very different consistencies. It could be a little bit mucousy or stringy. You may see stool that has white flecks in it or something that looks like little seeds, or it could be so runny that it soaks into the diaper. All of these things that would be considered normal. We're only counting stools that are around the size of a nickel as a stool, and each baby can stool very different sizes. One baby might stool with every single feed, smaller amounts, and another baby might have 3 large stools in a day. Both would be considered normal. The only thing that wouldn't be considered normal to see in your baby's stool would be if you noticed any blood. Blood can appear in the diaper as sort of a reddish color or even a little bit darker. If you ever see blood in a diaper, you would want to keep that diaper and make an appointment to go see your family doctor and bring it with you. One last thing that would be not normal to notice once you were home with your baby after 48 hours would be if you noticed any of this rusty color in the diaper. This is something called brick dust urine. It literally looks like someone shaved a little bit of a red brick off into your baby's diaper. This can be normal in days 1 and 2, but if you're seeing brick dust urine past day 2, then that would be considered not normal and could be a sign of some dehydration. Again, if you were seeing that, you would want to keep that diaper and either bring your baby into your family doctor or the emergency department. Next, we're going to talk about baby's feeding cues and how to know when your baby is ready to eat. These signs you will have seen probably up in your room on the maternity ward. It shows a baby in 3 different states of cueing. So early cues are when your baby is just starting to rouse. They may be moving around slightly, opening their mouth, or turning their head from side to side. This is the best time to pick your baby up for a feed and place them skin to skin. Mid cues are the baby saying, "I'm really hungry now." Stretching, increased physical movement, and placing their hand to their mouth and sucking on it. Those are mid cues. You're really going to want to start feeding here before your baby escalates quite quickly into the late cues of hunger. So late cues are crying, agitated body movements, and turning quite red. It's very, very difficult to latch a baby that is crying and has waited this long to feed. So it's important for you to try to calm your baby first to bring them back into a more organized state for feeding. Some of the ways that you can calm your baby would include swaddling, gently rocking, shushing, speaking gently to your baby, and also placing them skin to skin. When placing a baby skin to skin to calm them, it's best if you take them right down to their diaper and place them directly upright on your bare chest in between your breasts. While you're calming your baby, you can also use your index finger inside your baby's mouth, touching the hard palate, to stimulate them to suck on your finger, and this will also help them to calm down. Once you've calmed your baby, that's when it's a good time to start trying to latch. So one of the common ways that moms often will bring their baby in to latch is by simply bringing their baby close to the breast and then attempting to push the breast into the baby's mouth. When you aim your breast towards your baby's mouth, what happens is the nipple actually goes down towards the tongue, which does not stimulate the baby to suck. And what you will often see when you're latching your baby this way is they're eager to latch, they go on, and then they just sit there and don't suck. Or they might shake their head back and forth as if they can't figure out how to latch, or just fall asleep. So what we suggest is two things. One, always, whatever position you decide to use, there's no right or wrong position as long as it's comfortable for you, comfortable for your baby, and allows your baby to transfer milk. But there are two things you can do to kind of encourage a deeper latch and make breastfeeding more successful, which is first turning your baby in towards you, tummy to tummy. And when you're bringing that baby up to latch, you are lining up their nose with your nipple instead of their mouth. So lining up their nose to their nipple, their nose to your nipple, waiting for a big open mouth, and then bringing your baby onto your breast versus bringing your breast to your baby. You can see in this picture here, this mom has lined up this baby's nose to her nipple, causes the chin to hit the breast first, which results in the baby doing a nice wide open mouth. Bringing the baby onto the breast, you can see that the nipple is pointing up towards the roof of the mouth, which is then allowing the baby to latch on nice and deeply. Once you get your baby latched, there's a few ways that you can tell if your baby is latched on well and deep enough to transfer milk. When your baby is latched, you should be looking to see that you can see some areola above the lip and above the nose, whereas the areola, the dark part around your breast underneath, should be all tucked into their mouth. When a baby is latched well, it should not hurt. There should be no pain with this latch. If you're experiencing pain, the most common reason for that is that the baby is just latched on very shallow, possibly just holding your nipple in the mouth. The second thing you want to look for a nice deep latch is you want to have a look at your baby's cheeks. When a baby is latched on nice and deep, their cheeks should be nice and puffed out, like this, not sucking in while they're drinking, like this. If you see any dimpling in the cheeks while your baby is drinking, you want to take your finger inside their mouth, unlatch them, and relatch them again to try to achieve a deeper latch. There are many different positions that are used in breastfeeding. Common positions are positions such as cross cradle, where you're holding your baby in one hand, holding your breast in the other hand. Another common position is cradle hold, where you're simply cradling your baby in your arm, like this. And another common position is football, where you're tucking your baby underneath your breast and bringing them on in this position. Again, there's no right or wrong. Whatever's comfortable for you and comfortable for the baby and allows them to drink and transfer colostrum or breast milk is effective. However, there are a couple of tips that we can give you towards achieving a nice deep latch in a very comfortable position. What we suggest is starting with your baby each feed, skin to skin, upright on your chest. Babies that are laid on their tummy will automatically start to bob their head around and try to look for the breast. While your baby is on your chest, this works well for a baby that's very upset or a baby that is sleepy. What I encourage you to do is, while you have your baby skin to skin, is work by doing a little bit of breast massage combined with hand expression to sort of ready your breast so that it's easier for your baby to transfer colostrum once they do get latched. So for breast massage, you want to imagine that your breast is like the wheel of a bicycle and there's spokes. You want to massage down towards the nipple, all the way around your breast, and go around once or twice, just to sort of warm the breast up. This also helps if your nipple is a little bit on the flatter side. Sometimes the breast massage alone will help bring that nipple out, which will allow your baby to latch easier. Once you've done a bit of breast massage, you want to move on to doing some hand expression. Remembering that there is no milk located, there are no milk ducts in the dark part of your breast, in the areola. The milk ducts are all far back in the breast tissue. So when you get ready to hand express, you want to make sure that you're making a C with your index finger and your thumb, and you're placing those each about a ½ inch behind where your areola ends. Most commonly when I ask moms to show me how they've been hand expressing, they'll do something like this. They'll compress and just kind of roll down to the nipple. It's not that effective because, again, there's no milk ducts here. Instead, your first step is to make a C. Second step is to pull your breast in firmly towards your chest wall or your ribs. Once you've pulled your breast back, then you want to compress the breast together without really rolling down to the nipple. The first time you do this, you may not see any colostrum. That's okay. It takes about 5 or 6 sucks from a baby for them to get any colostrum in their mouth, and hand expression is no different. Colostrum is very thick like honey, and you have to work it down from the milk ducts down towards the nipple. So we're going to continue to do the hand expression a few more times. So we're making a C, pulling back, and compressing together. You can move your hand around, making a C, pulling back, and compress together. Once you start to get a few drops coming, you can simply take those with your finger and put them up to your baby's mouth or nose. This will help either calm them or help wake them if they are a little bit sleepy. Once your baby's calm or starts to show signs of interest in latching, what I suggest is positioning yourself in a more laid back fashion. So having your feet up on a stool, push your bump forward, and as your baby starts to bob around, you can gently just guide them over towards the nipple. In this position, you don't really need to worry about your baby's bottom. You're focusing more on controlling their neck and their upper shoulders as you're bringing them over to latch. I'm going to turn this way so that you can see the way that I'm lining the baby up with the nose. So bringing their nose up to the nipple, and then once you see that big open mouth, moving your baby onto your breast. As soon as your baby latches and starts to suck, you want to do a nice firm breast compression. So a breast compression is different than hand expression. Breast compressions is just a firm hold while the baby is active. This increases the amount of colostrum or breast milk they are able to get for each suck. So it just increases their intake. When your baby's sucking, you would compress. When your baby stops sucking, you can relax your hand, pull your baby in, give them some pressure on their back, and then compress again as they start to drink. You want to allow your baby to stay on the first side until you can no longer stimulate them to be doing some good deep sucking. So what you're looking for there is a lot of jaw movement. When your baby's latched and drinking well, you should be seeing their jaw move right up to their ear as they are sucking. Once you can no longer stimulate the action, then you can either take your baby off, or they may unlatch themselves on their own, place them upright on your chest, and then follow the same steps to latch them to the second side. We always recommend offering babies to both sides each feed, followed by hand expression and giving them some extra drops, either just from your finger to their mouth, from your breast to their mouth, or using a spoon. That brings us to our next topic, which is spoon and cup feeding. So, a lot of the time, because we're an early discharge hospital, feeding gets off to a pretty good start, and then parents feel pretty confident and they're ready to go home. Often when parents are going home, the baby has been sleeping, being woken up for feeds, feeding, and then going back to sleep. Between 24 and 48 hours is typically when cluster feeding behavior will start for normal newborns. Cluster feeding is different than regular feeding because the baby will be interested in feeding more frequently, sometimes every 15 to 20 minutes. It's very common within that 24 and 48 hour period, or typically the second night after baby is born. This can be very, very distressing for parents, for new parents, especially first-time parents, when they take their baby home. Having a baby that was eating and then sleeping consistently, who now is wanting to eat very, very frequently every 15 minutes, half an hour or so, can cause parents to worry that maybe their baby is not getting enough just from breastfeeding alone. Remember that cluster feeding is completely normal newborn behavior, and there's a reason that babies do it. Your prolactin levels, a hormone in your body, which is your milk-making hormone, are the highest after birth. And in order to make a good milk supply for long term, your breasts need to be stimulated often in that early period to take advantage of those prolactin levels. So between 24 and 48 hours is when your baby really starts to wake up and wants to nurse frequently to then increase your milk supply. It is the most common time that new parents will opt to supplement their newborns for non-medical reasons with formula because they're concerned that the baby's not getting enough. The best thing you can do during cluster feeding periods is try to stay calm, feed the baby, continue putting to the baby to breast when they're cueing. If you get to the point where the baby is no longer willing to latch but is still acting and showing signs of hunger, or mom needs a bit of a break and needs 5 or 10 minutes to not be breastfeeding, you can then move on and either use cup or spoon feeding to sort of get you through this difficult period. So to perform cup or spoon feeding, we'll talk about first because it's the most useful to you in the first few days of life. So typically I will suggest if your baby is no longer willing to latch and still acting hungry, give baby to dad, have dad wrap baby up in a blanket with their arms inside. It's the only time we recommend swaddling with the baby's arms in so that they aren't able to grab onto the spoon that might have really hard, it might have colostrum that you've worked really hard for. You don't want it to spill. So wrapping that baby up nice and tight, and dad will hold baby, or mom if she wants to, hold baby up on the lap. While dad is settling baby down, mom's gonna work on hand expression. So again, we're going through the steps of hand expression, massaging the breast, and expressing drops onto the spoon. It works really well if you have 2 spoons. So mom has the first spoon and she's working on hand expressing drops. And once she gets a good amount of drops on there, she's gonna pass that spoon to dad and continue trying to hand express. Once dad has a spoon with a little bit of colostrum on it, if it's just drops, you can literally just wipe those drops off and place them inside the baby's mouth. If you've got a little more than drops on here, maybe 2 or 3 mils, you can actually just bring that right up to the baby's mouth. If the baby's really crying or sleepy, you may need to get them to suck on your finger for a minute or 2 first to get them interested in eating again. As soon as you get them sucking, take your finger out and place the spoon against the bottom lip close to the baby's mouth. The baby will then do one of 2 things. They will either bring their tongue out like a kitten and lap up the colostrum off the spoon, or they might wrap their lips around the spoon and sort of slurp it out of the spoon. Both are fine. The idea behind this is that it's driven by the baby. So we're not tipping the spoon and dumping it into the baby's mouth. We're simply letting them lick it off the spoon or slurp it off the spoon. And that's why the baby's in an upright position, and we've gotten them interested in feeding by letting them suck on our finger. Cup feeding is exactly the same. This would be something you would use a little bit later in week 1, where your baby would need a little bit more volume. But cup feeding is a great option if you are separated from your baby and have expressed breast milk that you want someone else to feed to your baby for you without using a bottle. And we'll talk in a moment why that's important, why cup and spoon feeding is more protective of breastfeeding than offering bottles. So with the cup, same idea. The cup works best and is safest if it's full, so if it has 25 to 30 mils in it, even if that's not how much the baby's going to take. And then what you want to do is get the baby to suck on your finger again. Once they're getting really organized with their suck there, take your finger out, and you again just want to rest this cup on the baby's bottom lip, just tilted enough so that if the baby brings their tongue forward or closes their lips, they're going to see that there's breast milk there for them to slurp up. And they will do exactly the same thing as I mentioned with the spoon, either bringing their tongue out to lap it up or wrapping their lips around the edge and slurping the breast milk out of the cup. Many parents will ask, why a cup and a spoon? Why wouldn't we just opt to give the baby a bottle with breast milk if breastfeeding's not going well or the baby's unable to latch? And the reason for that is that babies use completely different muscles in their face for breastfeeding than they do for bottle feeding. However, cup and spoon feeding use the same muscles in the face as breastfeeding. So that just allows them to strengthen those muscles, hopefully to benefit them from being stronger then the next time they go to breastfeed. The other benefit is that the baby must be able to bring their tongue down and out in order to cup or spoon feed effectively, which is also what they need to do at the breast. So it does help them to achieve a little bit better of a latch. Whereas when a baby drinks from a bottle, their tongue is actually held quite far back in their mouth, and it's more difficult then to transition back and forth between offering the breast and offering the bottle. It can cause some issues with latching. So that's why. If you haven't received a hand expression kit, please ask your nurse for one. It's a kit like this. It has an instruction sheet in it which has all the instructions I just discussed for hand expression, and also comes with a cup and a spoon that you can then use to offer your baby extra drops at the bedside while working on breastfeeding. It's important to remember that the World Health Organization does recommend breastfeeding exclusivity for the first 6 months of life and continuing for 2 years and beyond. If you're having difficulty with latching past 24 hours of age, you can also ask that your nurse puts in a lactation consultant assessment, and we will be available to you to come and assist you with latching at the bedside. Our lactation consultants are available Monday to Friday from 8:30 to 4:30 p.m., 7 days a week, and we are available by being paged to come to your bedside. Thank you for watching the term breastfeeding class, and happy breastfeeding.